Welcome all. We would like to start. Welcome all to our second ASBMR Early Stage Investigator clinical case workshop. Today we have two topics, chronic kidney disease and bone health and calcium disorders. First, we start with the presentation from Professor Dr. Martine Cohen-Solal and Dr. Thomas Funck-Brentano from the University of Paris, France, and they will present their case on chronic kidney disease and bone health. Professor Dr. Martine Cohen-Solal is Professor of Cell Biology and a rheumatologist in Lariboisière Hospital in Paris. And she's Director of the Bone and Joints Research Unit and also Director of the Reference Center for Rare Bone Diseases. Her main interests are physiopathology of bone fragility in osteoporosis, rare metabolic bone diseases, and chronic kidney disease. Dr. Thomas Funck-Brentano is Associate Professor and Rheumatologist in the University of Paris Lariboisière Hospital and a member of the ECTS Academy. His areas of interest are rare bone diseases, secondary osteoporosis, in particular following organ transplantation, and osteoarticular complications of end-stage renal disease. This session will be moderated by the Early Stage Investigator Committee member, Dr. Elena Zurdi from Dresden University in Germany. Before the case presentation, there are some multiple choice questions, which will be repeated at the end of the talk. And after the presentation, all attendees get the possibility to ask their questions. Please use the question and answer button to ask these questions, which you can send already during the talk, so we can have the discussion with the questions and answers afterwards. Please go ahead. Thank you.
Thank you very much for the introduction. Hello, everyone. So I'm Thomas Funck-Brentano, and I'm together in the same room. We're not wearing masks, so just please forgive us for that, but we thought it was nicer. So we're just quickly going to start with this first clinical case, if it works. Now it should be working. So here are our disclosures. This is the case of a 7-year-old woman who was referred to our center after several medical history. So her renal medical history started very early in her life during her pregnancy, where she had a chronic renal failure with a diagnosis of glomerulonephritis. She went early to dialysis from 87 to the 90s with 2 renal transplantation, and unfortunately in 2017 this wasn't functional anymore, and she went back to dialysis. She didn't want to have a 3rd renal transplantation. She has other medical history with atrial fibrillation. She had an acute cerebellar ischemic stroke, hopefully without any consequences on the long term, hypertension, esophagitis, and a rather recent history of pneumocystis in 2017. Yeah, I don't know why I can't change my slides. Here. So here's her therapy. She's taking Sevelamer, prednisone. She was still on prednisone at that time after transplantation. She was also with sulfamethoxazole and trimethoprim because of her pneumocystis, taking warfarin, bisoprolol, and some statin. Her recent history is actually following her hospitalization for pneumocystis, and this was actually quite complicated for her. She lost a lot of weight, 10 kilograms, and had multiple fractures of the ribs, probably due or related to her coughing and respiratory rehabilitation. A few months later, she also encountered a spontaneous fracture of the sacrum just by walking. And so that was diagnosed at the time. So this is the first question, and we're going to use the poll here. So what are the important clinical elements for the evaluation of her fracture risk? So we leave you at 30 seconds or so to answer. Please give it a try. Okay, I think we're gonna to go for it. Yeah. Okay. So
so the audience are right finally, because if I understood well, everybody answered that the 5 items were great, so we are having a little bit of troubles with that. So
yeah, it is.
So the answers are the personal history of fracture, for sure, the low BMI, also the other endocrine disease, and we need to look for other endocrine disease to the evaluation of fracture risk, even if they have severe renal failure, the history of corticosteroid, and also the number of falls within the previous last months. So all the items were correct. And we have to say that this is something which is underestimated in nephrologists. They do not take enough care about the classical risk factors that we use when we see patients like endocrine and rheumatologists. So the classical risk factors are extremely important for the evaluation, even in dialysis patients. There is one additional factor that we forgot to put, and maybe if the audience has one of the idea about what is the other item we should have put, we will give you the answer at the end of it.
Okay, some suspense.
Yes.
Okay, so I'm probably going to go on for the purpose of time. So here was the DEX at the time in 2018. So this is in the past, so it's in black and white. Forgive me for that. You can see that she had clear signs of osteoporosis at the spine with a T-score of minus 2.7 or 2.9 if we look from L2 to L4. And looking at her hip, well, so sorry, it's in French, it's a real case, of course. So col is for neck, and total is for total hip. I guess you can follow that. She was quite low already with a minus 3.1 T-score at the femoral neck. So at the time, the nephrologist didn't really go much further for the evaluation of her bone health. And she received some symptomatic treatment for her pain. Their idea was to improve her general health conditions, improve her nutritional factors so that she could gain a little bit of weight, have some, improve her protein intakes, and also her physical activity. More specifically, she started some vitamin D agonists with alpha-calcidyl and cholecalciferol, as well as calcium supplements at that time. And the idea was to follow her medically, clinically, and with another DEXA. And actually, it didn't go so well. So she had persistence of pain in the sacrum, ribs, knee, ankle, and she could hardly walk. It was actually really difficult. And despite some gain of weight, plus 5 kilograms, she was actually still with a very low BMI, around 18. So this was actually conducted to some bone scan prescription at that time, and you can actually see some hot spots at different regions still in the sacrum. So she still had some active, not consolidated fractures of her sacrum, but also other fractures or pseudo fractures at the talus, or at her femoral condyle here. So at that time, she was referred to our center for some evaluation. And the next question is actually for you, is what would you prescribe at this time? If you can have the poll. Yeah, great. A few more seconds.
Okay.
Okay, perhaps we can go for it.
Okay, so Thomas, apparently everybody, the majority prescribe the DEXA, the X-ray of the pelvis and the spine, but do not prescribe the skull and the hands, and no MRI of the spine. So now...
Yeah, so let's just look at our answers.
Yeah, so what we did is to prescribe, so it's coming, okay, so we prescribed an X-ray of the pelvis to check about the fracture, the X-ray of the spine in order to evaluate if there is any vertebral fracture. Also, we check also for the arterial calcification, and one good thing is to do also the X-ray of the skull and hands, because we could see at the hand the vascular calcification, but also the erosions that could occur when there is an hyperparathyroidism. The skull is also a good test to see if there were in the past secondary hyperparathyroidism. For us, MRIs of the spine is not useful because we could see the vertebral fracture on the X-rays, and of course the DEXA for everybody answer the right one.
Yeah, so also for the X-ray of the pelvis, so that might be a rheumatologist point of view, of course. Yeah. It could be different, but you know, she has really an extreme difficulty to walk, and it's difficult to know whether it's really due to the fractures, or it could be also to hip osteoarthritis, or other complications. So each time you have a hot spot on the bone scan, you need to confirm this by at least an X-ray. So this is actually the imaging that we did, some X-rays of the full spine. This is using EOS imaging system. Here you can see, I hope you can see that there was actually no vertebral fracture. This is actually quite important to picture. We know she has at least a sacrum fracture. She has a callus here, you can see here. But no evidence of vertebral fractures. We can imagine her aorta right here, but there's no extreme vascular calcification that we can see here on these images. And this is what Martine was telling me about with the skull, and there's no evidence on the skull or hands of osteoitis fibrosa or other signs of hyperparathyroidism.
And in particular, there is no salt and pepper aspect of the skull, which is an indication of severe hyperparathyroidism in the past.
Yeah. So we repeated the DEXA a year after, and what we could see was no clear evidence of a change or worsening at the spine, but clearly at the hip, she still lost some weight despite lost some bone mineral density. Sorry, with marked change and worsening of her, especially femoral neck BMD. Would you do any lab tests, and which one of those would you do? Probably going to go quickly on this one. Okay.
Okay.
I think we're all good. Yeah. So we agree with all of you.
Yeah. So everybody gave the good answer, apparently.
Yeah. No wrong answers on this one.
No wrong ones. So everybody asked all the tests, and we agree with you. All of them are very important for the evaluation of the mineral metabolism in dialysis patients. So let's see now what were the results of the tests. Thomas, yes?
Should I comment on this?
Yes.
Okay, so she had normal values of 25 hydroxy vitamin D, and her calcium and phosphate levels, actually total or ionized, were actually normal. What we can see is also her PTH levels, which is at around 300, which is in the window, 2 times to 9 times the upper normal range. CTA, so looking at bone turnover markers, she had slightly elevated bone alkaline phosphatase levels at 29 for a normal value below 22. And this is actually an interesting one because it's not cleared by the kidney. So it's actually a good marker for bone formation. CTX were really high, but this one is actually hard to interpret because of her renal failure, of course, and also because she had recent fractures, and we know that this can interfere. For P1 and P, it's not fully clear to know how to use it in those patients and how to interpret the results. As the intact form is also cleared by the kidney.
Okay, so I have two messages on these slides. First of all, the 25 hydroxy vitamin D is very important in dialysis patients. Most of the time they may have a lot of osteoid, and they will need more vitamin D supplementation than the usual non-kidney disease patients. And here the target is achieved, but sometimes we need to go to 40 to 45 nanogram per ml. So this is one thing that we have shown previously. And do not forget to ask for bone mineral and also the specific bone biomarkers, which this is not usual to do it, but it's really complementary to the PTH. And in that case, we can see that the PTH is in the target, but the bone alkaline phosphatase is a little bit above. And it has been shown that the combination of the PTH and bone alkaline phosphatase improve the prediction of the rate of turnover. the level of turnover.
Yeah, so I think now is time to have a little bit of explanations on the different bone diseases in CKD-MBD.
Yeah, so this is the physiopathology, and this is the ASBMR slides, which is a very good one. So the chronic kidney disease also give rise to different kind of mechanisms such as inflammation, iron depletion, a lot of different molecules that could be disturbed. The main one is the phosphate retention that gives the hyperphosphatemia and the decrease in 125 vitamin D, and all of them increase the PTH level. And this is one of the main and the classical cause of bone fragility because we have also this high bone turnover. In addition to that, we know now that there is altered osteocyte biology with a lot of Wnt inhibitors that also will induce low bone turnover. What is missing in these slides is that the majority of the patients on dialysis or with end-stage kidney disease have also vitamin D deficiency. And this will contribute to another kind of low bone turnover, which is osteomalacia, that we do not see really without kidney disease. So there is a lot of different mechanisms, and this slide show you that there is now a unified classification called KDIGO, where they try to integrate different manifestations of patients with the CKD-MBD. And the originality of that is that most of the patients with bone diseases also have vascular disease. And you can see that there is different category of the manifestations. So the biology, which is not normal in CKD-MBD patients, while normal in the non-CKD patients. And you see also that there is a bone category which include the bone volume as the usual patients, but in addition to that, the level of bone remodeling and the mineralization defect then really can occur in this patient much more frequently than in non-CKD patients. Here, this is a slide to show you that we cannot rely only on fracture and only on BMD, because it has been shown that BMD is not really a very good test to predict the bone fragility. Most of the patients has normal BMD. This is not the case here, but most of the dialysis patients at least. So bone disease in CKD does not mean exactly the same than in osteoporosis, because the fracture can occur at any of the bone disease pattern. You have on the left-hand side some example of low BMD that could be due to osteomalacia. You see here that there is a light blue, which is osteoid, but also the so-called dynamic bone disease, which is very close to what we see in low bone turnover osteoporosis, and of course the mixed osteopathy. So there is no way to differentiate both only using the BMD. Whereas in hyperparathyroidism, the BMD could be high, normal, or sometimes also low. So another marker that could be useful to evaluate the rate of bone turnover that impact the fracture risk is the PTH. And you can see here on the left-hand side that the risk of fracture is increased if the PTH is low. Around the circle, you can see that the PTH is below 2 times of the normal range. And this is considered as completely abnormal. So the fracture can occur if the PTH is low, and also on the right-hand side, if the PTH is high, because of the impact of the PTH on the cortical bone. And we know that after parathyroidectomy, there is a decreased risk of fracture. So in summary, low PTH or high PTH is not really good for these patients, and we should target really the range between 2 and 9 times the PTH, the normal value.
So in our case here, it was difficult to picture using the biology to know in which situation we were, whether adynamic. We didn't really have biological signs of adynamic bone disease, but it was difficult to assess whether she had high bone turnover, osteomalacia or not. What we know is that she had severe and recent fractures and pseudofractures, and that she was continuing to lose bone. So we really wanted to do something, and we went to the Transilic bone biopsy, which results are pictured here. And just to go very quickly, what we could see was a generally low bone mass, and we still had some selectivity here. So for some technical reasons, we did not have the bone formation rate using the double label marker. But clearly there was no sign of adynamic bone disease in this patient. And we could also see some clusters of osteoclast on the cortical surfaces. So with persistence of bone cells and no osteomalacia and no clear evidence of adynamic bone diseases, we decided to start therapy and initiate denosumab. Of course, you are all aware of the high risk of hypocalcemia in those patients, and this was clearly monitored but well tolerated by the patient. So Martine, do you want to go on and comment?
Yeah, just to finish, to give some guidelines about bone fragility in CKD. We first believe that we do not have to treat the low BMD only because we have no evidence that treating low BMD in CKD patients will improve the fracture risk, but we do treat if they have severe fracture. We will focus just in the middle of the panel when the PTH is within the target. We measure the bone alkaline phosphatase, and if it's high, we treat first with calcimimetic, and then if it's low or if it becomes normals, we will do a bone biopsy just to make sure that there is no mineralization defect. So for us, it's quite easy because we have the lab, but this could be avoided if you have bone markers completely normal. And then the best treatment so far is denosumab because there is no contraindication in relation with the kidney failure. So those are the guidelines. I just would like to say one word about the PTH. When the PTH is low, just to make sure that there is no mineralization defect and osteomalacia, no hypocalcemia or hypophosphatemia, because in that case, denosumab will not be the best treatment, the best option of the treatment. Okay, so the take-home message is that we know that the prevalence of fracture is very high in CKD patients. This fracture can occur in each bone feature, its bone type, I would say, and with high and low PTH. So there is no relationship between those markers and the bone fragility. We used to treat only the patients with fracture and not with the low BMD. We do not use bisphosphonates because of the retention of bisphosphonates in the bone and the induction, the possible induction of mineralization defect. Whereas denosumab is now under evaluation in many groups worldwide. Okay, I think this is finished. We are a little bit late, 2 minutes too much.
Yes. Thank you, Thomas and Martine. This has been a very comprehensive and didactic case, and indeed we're a bit ahead of time, but it has woken an active interest here, and we have a lot of questions about the case per se. So one of our audience wanted to ask about the timing of biochemistry in terms also to imaging. So why, I don't know if it's just how you presented it, or would you normally do the biochemical, the lab evaluation before organizing the imaging?
I think this is actually, it was a real case story here. So this is actually what happened to the patient in real life. And I think one of the messages that perhaps her nephrologist at the beginning didn't really, she was recovering from a severe disease, and they probably didn't take this into consideration so much. So this is actually real life situation. Of course, this should have been done from the beginning in 2018. I fully agree with that. And there was no reason to wait. So this is a quick answer. So about the imaging, it's pretty much the same. And why did we do this a year later? I think it's for the same reasons. Why did we choose a bone scan? It could have been an MRI actually or other imaging. Or just start with X-rays normally. Bone scan can be useful, of course, when you have a lot of pains everywhere in the skeleton. With only one exam, you can spot all the different regions, and then go where you have some uptake. So this was the reasons, basically.
Okay, thank you. We have quite a lot of questions also about treatment, and especially denosumab and the very known effects of denosumab discontinuation, about rebound effect, and how would you go about this in terminal kidney insufficiency. There is also another question, if one could do, maybe probably not in terminal, but maybe CKD3 or 4 oral bisphosphonates. And I think there is also a paper in the JBMR who was looking into this this year. So would you see a place for oral bisphosphonates?
Yeah, for oral bisphosphonates for the CKD stage 4. As soon as the GFR is below 30 milliliters per minute, we will not be able to use the bisphosphonates, but above this threshold, we use it. For sure.
Yeah, and mainly risedronate is the one where you have more evidence of
yes,
efficacy.
indeed, there was a comment from Professor Duncan about risedronate, was exactly spot on. Then there's another question about using denosumab in lower doses in order to avoid hypocalcemia. But I take it that another way of going about this would be then to substitute calcium to these patients.
We give denosumab at the same schedule that we use for osteoporosis, 60 milligrams every 6 months. And in that case, because we have no idea about how to do it another way, there is no trial about that. And to our knowledge, if we supplement correctly in vitamin D, the hypocalcemia is less. And in addition to that, we can substitute with calcium just within the following weeks of denosumab, and we do have much less hypocalcemia. Of course, all those are completely, we have no idea about the fracture, but at least they have, we hope that they will have a stronger bone. Yeah. So there is one question about teriparatide.
Yes.
So there is no trial about that either. We do not use it because we do not understand what's going on with PTH, with endogenous PTH. And those patients, they have very, very high level of PTH. So given just a few microgram more of PTH, I'm not sure that it will do anything.
Well, there was some discussion about a possible interest of teriparatide in patients with dynamic bone disease, which was not the case patients. So, but I think we're really looking forward for, bigger trials and bigger evidence to use these different drugs in those quite, complex but frequent situations.
Yes, thank you, Thomas and Martine. It has been a real tour de force, very interesting case and very nice discussion. We will now give it back to Lisbeth.
Well, also thank you very much, Martine and Thomas, for this very nice, excellent presentation with the lively discussion as well. Now we will move on to Dr. Marc Wein and his trainee, Dr. Maria Stamou from Massachusetts General Hospital, Harvard Medical School in Boston. They will cover the topic on calcium disorders. Dr. Marc Wein is endocrinologist and associate professor at Harvard Medical School, and he is an expert in signaling pathways downstream of the parathyroid hormone action in bone and mineral metabolism. And Dr. Maria Stamou is second-year endocrine fellow at the same hospital, and she started her clinical training at Harvard Medical School after she received her MD and PhD from Patras University in Greece. This session will be moderated by the Early Stage Investigator Committee member, Dr. Sabashini Ramchand from Harvard University. And again, the presentation will be started and closed with multiple choice questions, and then we have time for the questions and answers, and please again send them through the question and answer function already during the presentation. Thank you. Go ahead.
Hello, everyone. I would like to thank the ASBMR committee for giving us the opportunity to discuss today about calcium disorders. So I'm going to be talking about a case with Dr. Marc Wein, and starting with our case. So this is an 82-year-old male with history of kidney stones, remote history of prostate cancer, gout, distant sarcoid osteopenia, and CKD stage 4, who presented with fatigue, nausea, and vomiting. So at presentation, his calcium was elevated, it was 13.5, had a normal albumin, and his creatinine was 2.6 with a GFR of 22, which was high, but it was at his baseline. So our first question to our audience is that what would you do next? This is a patient, I don't know if we can pull up the poll for everyone to vote. But so just to remind you, 82-year-old male, history of distant sarcoid, remote history of prostate cancer, presenting with hypercalcemia. So one option would be to start fluids and check a PTHRP. Second option, to give zoledronic acid and check 125 hydroxy vitamin D, start IV fluid and check PTH, get a bone scan, check ASBMR or start cinacalcet and refer to endocrine surgery. We can give it a few more seconds to complete, like 1 minute. I think we do have an answer here. So the majority of people voting that start IV fluids and check PTH, which is what we did. And just to refresh the memory for everyone, that whenever we have a case of hypercalcemia, we should start from scratch. We just give fluids and check a PTH. And we did check a PTH in this case, and it was found to be elevated at 111. He had a normal 25 vitamin D. So the reason we want to check a PTH whenever we approach a case with hypercalcemia is that whenever it's elevated, that leads us towards a diagnosis of primary hyperparathyroidism. However, when it's not, we should rule out other causes such as medication-induced hypercalcemia or vitamin D intoxication, milk alkali syndrome, and then check other labs, including PTHRP, that will lead to hypercalcemia of malignancy, 125 hydroxy vitamin D, suggestive of granulomatous disease or lymphoma, ASBMR to rule out multiple myeloma, and of course a 25 hydroxy vitamin D, as vitamin D intoxication can lead to hypercalcemia. So for our case, so his calcium was elevated, he had an elevated PTH. So what was done is that he was given IV fluids and he got a dose of zoledronic acid in the emergency room. So we wanted to differentiate between primary hyperparathyroidism in this case and tertiary hyperparathyroidism in the setting of his CKD. So to do this, we got imaging of his parathyroids, including a Stamou scan that showed increased uptake in one of his parathyroid glands, suggestive of an adenoma. However, given his age and comorbidities, and after having an extensive discussion with the patient, he decided not to pursue with surgery and just see how he would do with hydration and antiresorptive therapy. So initially his calcium level improved, normalized. However, that lasted for only a few days because a few weeks later he came back with an elevated calcium, and of course PTH elevation had persisted. So at that time we gave him denosumab therapy, mostly to protect his kidneys since he has CKD and denosumab is preferred. And we can see that calcium improved after the second round of treatment. But again, a few weeks later, it was still elevated and even higher at 14.1 with an elevated PTH. So at that moment, he had come back to the ED with the same symptoms, received IV fluids, and he got a dose of zoledronic acid. But given the fact that his hypercalcemia continued to be persistent despite antiresorptive therapy and hydration, he moved forward with parathyroidectomy, and it was a left upper parathyroid adenoma was removed and was confirmed by pathology. So he was actually doing well for a few weeks after the surgery. However, surprisingly, his calcium started trending up again only 1 month after his surgery, which was pretty surprising because we had also had him off any calcium supplements, given that his calcium after the surgery, given that his calcium levels were normal. So at that time, we were actually wondering what was going on. And as you all of our audience agreed earlier, the first thing to do when there's hypercalcemia is to check a PTH. So we ended up checking a PTH, and as we can see, it had dropped from the 200s to 13. So this time, a month after his surgery that he was treated for primary hyperparathyroidism, he had a second process going on leading to hypercalcemia. Which was PTH independent. And just to remind us all, PTH independent hypercalcemia could be secondary to malignancy, either through a PTHRP dependent process or through osteolytic bone metastasis, could be secondary to vitamin D intoxication or any chronic granulomatous disorders. Other rare causes of PTH independent hypercalcemia include hyperparathyroidism. For this case, his TSH was not suppressed. Also adrenal insufficiency. He had an AM cortisol that was above 18, ruling out adrenal insufficiency. Also his vitamin A level was normal, ruling out vitamin A toxicosis, and he was not on any supplements. Also he had normal SPEP and UPEP, ruling out multiple myeloma. Given his prior history of prostate cancer, we got a skeletal survey that did not show any bone lytic lesions. He also had a low PSA, and PTH was also a low, suggesting that it was not related to malignancy. However, he did have this remote history of sarcoidosis, so we checked on 125 hydroxy vitamin D, which was high. It was slightly elevated, but definitely higher than we would expect in a patient with CKD, where the conversion of 25 to 125 hydroxy vitamin D is impaired. So we did get a CT of his chest that showed bilateral lymphadenopathy and changes consistent with sarcoidosis, and we actually reviewed that with radiology and compared it to his very first CT scan of his chest that he had 20 years ago when sarcoidosis was first diagnosed. And the changes were in the same spot, but had slowly become worse by time, suggesting that his hypercalcemia was secondary to sarcoid this time. And I will pass it on to Dr. Wein.
Fine. Well, first of all, thank you to the ASBMR for this chance to talk about this case. So my job is to fill in some of the blanks and bring you all up to speed on what happened with this patient. So to remind you, normally we can get vitamin D either through the sun, through sunlight, or through dietary supplement sources, and that vitamin D is converted in the liver by CYP2R1 to 25-hydroxy vitamin D, and then the 25-hydroxy vitamin D is converted to the active form of 125-dihydroxy vitamin D in the kidney under the control of PTH. Advance the slide. And then that is kind of the active hormone that promotes calcium absorption from the gut and reabsorption in the kidney. And then 125 vitamin D is further degraded by CYP24A1. And so that's kind of the normal physiology of vitamin D conversion. And then if you go ahead to the next slide, we also, however, in patients with chronic granulomatous disease, and this is an image of the lung of a patient with sarcoidosis showing these classic non-caseating granulomas, we know that this same enzyme, CYP27B1, can also be expressed, which can convert 25-hydroxy vitamin D into 125 vitamin D, which leads to basically PTH-independent extrarenal production of 125 vitamin D. Advance the slide. One more. So why does this happen in the first place? It turns out that macrophages, which accumulate in sarcoidosis, as well as in other conditions where you have ectopic production of 125 vitamin D, have kind of a normal gene expression program where in response to bacteria, they upregulate the production of 125 vitamin D, which is important in turning on a gene called cathelicidin, which promotes killing of intracellular mycobacteria. So this is kind of a normal process that happens in our innate immune system in response to mycobacteria, but can become kind of abnormally turned on in the setting of these chronic granulomatous diseases. You can go ahead. So how do we really know this happens? There was a very interesting and important case report published almost 40 years ago that clearly demonstrated that 125 vitamin D can occur kind of outside of the kidney in a patient with sarcoidosis. So this was a patient with sarcoidosis who presented with hypercalcemia due to high 125 vitamin D, and he underwent a bilateral nephrectomy. And so that bilateral nephrectomy, really, if the 125 is coming from the kidneys, it should have cured him. But as the patient's prednisone dose was tapered, he actually developed a recurrence of severe increases in hypercalcemia and high levels of 125 vitamin D, clearly indicating that in a human who's had a bilateral nephrectomy, you can still have pathologic production of 125. So if you go to the next slide. And so, since that kind of in vivo demonstration, it's been demonstrated now by many groups that macrophages that are isolated from the lungs of patients with sarcoidosis can convert 25-hydroxyvitamin D into 125D, as is shown by this series of publications from the early 1980s. But then if you advance one more time. Furthermore, when the converting enzyme, CYP27B1, was cloned, it was possible to interrogate the levels of CYP27 expression in pulmonary macrophages from patients with sarcoid or without. And you can see that these sarcoid macrophages, for reasons that we still don't understand, express very high levels of the CYP27 vitamin D activating enzyme. Next slide. So what do we do for these patients? Really, the key for treating patients with high 125 is to treat the underlying disorder. So for patients with lymphomas, that's chemotherapy. If this is due to a mycobacterial infection, that's antibiotics. And for inflammatory disorders like sarcoid, it's to use immunosuppressive medications, which should hopefully treat the underlying inflammatory process as well as reduce the expression of CYP27. And then, of course, you want to avoid excess amounts of exogenous calcium intake while you're kind of sorting all this out. So if you go ahead to the next slide. This is kind of a beautiful early example of the efficacy of glucocorticoids in patients with 125D mediated hypercalcemia. This is a series of patients with non-Hodgkin's lymphoma, all treated with moderate doses of glucocorticoids with subsequent reductions in hypercalcemia associated with reductions in 125. And most likely glucocorticoids directly suppress the expression of the CYP27B1 gene in these infiltrating macrophages. And it's important to note that the kind of calcemic effect of glucocorticoids can take some time in these patients. So if the steroids don't start working, in one day, you need to have a little bit of patience. So next slide. In addition to glucocorticoids, there are some other treatment options that are used much less commonly in patients with 125D mediated hypercalcemia. So for example, ketoconazole, which is an antifungal agent, which is also helpful for some patients with cortisol excess, can interfere with cytochrome P450 function, including interfering with CYP27B1 function at high doses. And so this medication, although there can be problems with the tolerability, can be used to reduce 125D production for patients who cannot tolerate glucocorticoids. In addition to ketoconazole and prednisone, other medications like chloroquine or other therapies that may target more specifically the sarcoidosis, like anti-TNF therapy, have been reported in patients with sarcoidosis-induced increases in 125 vitamin D. The next slide. So this is kind of what happened with our patient. So now if you see, he first presented with PTH-dependent hypercalcemia, and then, just a few months later presented with PTH-independent hypercalcemia that was due to high levels of 125 vitamin D associated with his sarcoid. And his calcium has actually responded quite nicely to glucocorticoids. Nothing comes for free. And this patient did have problems with congestive heart failure after starting glucocorticoid treatment. So we've really had to kind of, walk a fine line between keeping his calcium in check and, monitoring his volume status and working closely with his cardiologist. But most recently, the patient has had normal calcium levels with prednisone doses in the 5 to 6 milligram range, although his calcium has increased when the prednisone doses have dipped down below 5 milligrams a day. So this is kind of a nice example of how, one cause, you don't necessarily have one explanation for hypercalcemia in a patient. And, perhaps the reason that this patient's initial calcium kept jumping up so quickly after anti-resorptive therapy is that, if 125D is driving it, that's going to also be coming from increased gut resorption and increased renal retention of calcium. So maybe in hindsight, it could have been a clue that there were actually two processes going on at once in this patient. Great, so go ahead to the next slide. Okay, so this is a question to test if you were paying any attention at all to what we were talking about. So where is 125 vitamin D normally produced? And then where does it come from in sarcoidosis? And so you can see the options listed here. Okay. Few more seconds. Okay. All right. Okay, so we're sharing the polling results. So it looks like most people were paying attention. So the normal conversion of 25 hydroxyvitamin D to 125 occurs in the kidney. And the same enzyme, CYP27B1, can promote the conversion, the extrarenal conversion of vitamin D into 125D in macrophages in sarcoidosis. And so that could, I guess the kidney lung and kidney macrophages is a little bit misleading because, the macrophages could be in other parts of the body. You could have sarcoid in the bone marrow or sarcoid in the liver. So I think that I understand where the people who voted for option D would be coming from, but I liked option E a little bit better. Great. So our final slide is really a summary of what we talked about. I do want to make sure that we have time to get to some of the questions. I think this case really illustrates how every patient with hypercalcemia is unique. And, having a systematic approach, first determining if it's PTH dependent or independent, and, kind of thinking as clearly as you possibly can be helpful. And I guess in hindsight, the fact that this patient kind of calcium bumped up so quickly after receiving the, doses of zoledronic acid and denosumab may have been a clue that there were multiple processes happening at once. And, this clearly demonstrates that it's possible to have, both PTH dependent and PTH independent hypercalcemia happening in the same patient at the same time. Thank you very much for your attention. I think we have a few minutes left for questions.
Yep. Maria, Mark, thank you very much. That was an excellent illustrative case with very important learning points. I just want to notify attendees that we did start late on this case, and just so you have enough time for questions, we will run 5 minutes over time just to allow a little bit more discussion time. So Mark, I'm just going to jump, and Maria, I'm going to jump straight into the questions. Some of them were about the diagnostic schema that you had for hypercalcemia. We have 2 questions on that. The first one is, would you consider FHH in your diagnostic sort of schematic diagram, and where would that go?
Yeah, I think that's a very important thing to bring up. FHH is a form of PTH-dependent hypercalcemia. And, you know, I usually have 2 ways of ruling out FHH. First is through chart biopsy. So for this patient, you know, I remember we looked back and, you know, 20 years ago, calcium levels were, you know, 9.0. And so that clearly indicated that hypercalcemia has not been present for a long time, which, you know, really points you away from FHH. You know, the neck imaging doesn't really, you know, cinch the diagnosis, because of course you could have dipsels in your neck for lots of different reasons. And so, you know, these are biochemical diagnoses. And so, you know, if you don't have the luxury of kind of previously normal calcium levels, then, you know, obviously the urine study should be performed before sending a patient for neck surgery. But, you know, I guess we kind of lucked out here, and, you know, a clear parathyroid adenoma was removed, and, you know, which kind of certainly indicates that FHH was not present. But, you know, FHH certainly belongs in your evaluation when you're dealing with causes of PTH-dependent hypercalcemia.
Okay, thank you. Following on from that, you mentioned the parathyroidectomy. There was a question about how many parathyroid glands were removed, and if it was just 1 or 2, would you run into problems with hyperplasia of the remaining parathyroid glands and potentially have tertiary hyperparathyroidism as a cause of hypercalcemia?
Yeah, that's a great question. So for this patient, a single adenoma was removed, and I believe the surgeon did identify at least 2 other glands in the operating room, which looked normal. Certainly having long-standing kidney disease is going to cause some hyperplasia of the remaining parathyroid glands. And, you know, be a risk factor for developing, you know, persistent problems with hypercalcemia down the road. You know, this patient's, you know, hypercalcemia shortly after parathyroid surgery was clearly PTH independent. So, you know, I don't think this was kind of related to his chronic kidney disease, but rather due to sarcoidosis. It's a great question. And, you know, Maria and I were talking about this beforehand. You know, the surgeons at Mass General love to use intraoperative PTH monitoring to help kind of get at this question. You know, there's quite a bit of debate and, you know, unclarity about the true utility, especially at like a dominant adenoma and, you know, some other glands that are hyperplastic. But, you know, I think here, you know, the visual observation of the other parathyroid glands and the fact that a single obvious adenoma was removed, you know, indicates that hyperplasia of the remaining glands not a major problem.
Okay. A popular question asked by a few people was the choice of zoledronic acid, given that this patient had stage 4 CKD, and also if you were to choose it, what dose did you give?
Yeah, so generally, this was kind of, you know, you could always kind of point fingers at other doctors, but I think this was given in the emergency room before endocrine was consulted. Is that right, Maria?
Yeah, it was given, both times it was given in the emergency room at presentation of the patient. The denosumab was given in the clinic when we saw the patient.
Yeah.
So it was before we had to evaluate him.
And so generally, I think if you're worried about hypercalcemia in a patient with renal failure, you know, there's ample literature about pamidronate as an option for treating hypercalcemia in patients with renal failure due to multiple myeloma and other causes. And so, you know, I think if I had to pick a bisphosphonate up front, I would have given pamidronate. And for an inpatient, you can just infuse it over like 6 hours or 8 hours. And that is kind of a good way to reduce the risk of nephrotoxicity. I think if you have to give zoledronic acid for whatever reason to patients with, you know, this degree of CKD, I would give like 2 or 3 milligrams and infuse it again over a very long period of time. But you know, this is what actually happened to the patient. Do you remember what dose he received?
I believe it was 4 or 5 one of the times, so it was not renally dosed, unfortunately. Kidney function remained stable. That was yeah.
Okay, great. 2 of these questions relate to interpretation of the biochemistry. The first question is, you talked about 25 hydroxy vitamin D toxicity. We know that some people have, fluctuating levels. What threshold would you consider a level above which you would consider it to be toxicity?
For 25 hydroxy vitamin D?
Yes. So I think in that schema you would measure 25 hydroxy and check levels.
Yeah, I mean, most patients who have, very high levels of 25 hydroxy vitamin D due to supplementation do not develop hypercalcemia. So, in my experience, you kind of have to have, impairments of renal function with reduced calcium excretion for vitamin D toxicity to lead to hypercalcemia. I think there are a lot of patients out there who are taking lots of supplements who have vitamin D assays that are greater than the range, than the 25 D levels that are over the assay range, who have normal calcium and their PTH may be slightly low. But all the patients I've ever seen who have, true hypercalcemia due to vitamin D toxicity have, levels that are greater than our assay detects.
Okay. The other question is about the cortisol levels. So in the setting of chronic kidney disease, how reliable is the serum cortisol given that cortisol binding globulin might be affected?
Yeah, it's a great question. I'm not kind of intimately familiar with the data on, total cortisol levels of CKD. This patient didn't have any obvious clinical features of adrenal insufficiency. If anything, he was quite hypertensive. But we were happy, we were fine with that morning cortisol level. But I think you're right. If there is a concern, you could either measure a CBG level, which takes about a month to come back for us, or you can try, a salivary cortisol, which isn't quite as well validated. But I know there's a lot of investigation into those kinds of tests.
Okay, perfect. I think we'll have two more questions and then we'll wrap it up. So this one is about prednisolone dosing. Someone has the question about how would you start prednisolone dosing and how long would you go for?
Yeah, that's a great question. So, I think we get a lot of input from our pulmonary colleagues on prednisone dosing for patients with sarcoid because, we endocrinologists, we like to give kind of, replacement doses of steroids, not, pharmacologic dosing. So this guy, this particular patient had pretty extensive pulmonary disease burden, and some of his shortness of breath may have also been due to the sarcoidosis. So I believe he was started on a dose of 20 milligrams a day of prednisone and tapered pretty slowly by like 5 milligrams every 2 weeks until he got down to 5 milligrams once a day, which, seems to be a adrenal insufficiency dose, but also a dose for, most patients with sarcoid where hypercalcemia is the issue to kind of keep it at bay. But, I think you need to just follow these patients very carefully and get input from your colleagues who kind of really know sarcoid to get a handle on what a good starting dose would be.
Fantastic. The last question. So this is an interesting one. So the coexistence of sarcoid and hyperparathyroidism, which are, they seem to be, they seem to occur a lot more commonly together than could be explained by chance alone. And so could you comment on your thoughts about why this might be so?
I don't know. It's a very interesting observation. And, I guess both conditions happen in older individuals, but that doesn't really answer, why they seem to be a little bit more common to occur. Boy, I don't know. We got to keep working on it. Great question.
I think we'll end the questions there. Marc and Maria, thank you so much for your time. I'm going to hand over to Elizabeth to close the session.
Oh, unmute.
Thank you. Well, I was just thanking you all for your attendance and all presenters for these excellent presentations with very nice discussions. We had nice, I think we learned a lot, all of us, and I would like to ask Lauren to put up the last slide, since before we close the session, I would like to point out that we have our next clinical case workshop scheduled at October 6th. With a presentation by Adi Cohen on early stage onset osteoporosis. Sorry. And another, there, okay, it doesn't work, but we have at October 6th, we have our next session on early onset osteoporosis by Dr. Adi Cohen and her clinical fellow, and another that still needs to be confirmed. And I'd like to see you all by then. You can register at the ASBMR site. Thank you all very much.
Thank you.
Thank you.